Assalamu alaikum. Welcome everyone on board. Uh, we had started discussing trauma, so we will continue from where we left yesterday. Any one of you have done this ATLS? Because usually some of the anesthetists do it. I really want to do it. I'm not getting the time to. Uh, this was the latest one, according to my information, was in 2018. I think it's not updated after that. And this is the full course manual, just like ACLS manual. We will just try to extract the basic information in this. So actually, trauma care is a very uh, uh, broad topic in which multidisciplinary teams are involved. And in the basic principles, I told that it will be very variable. Like it will be depending on the scenario which they had asked to you, um, and you just these questions may be asked in a number of ways, but the basic principle will be involving the immediate care, uh, and then the further definitive care. Okay. So whatever trauma, whatever the is the mode of the trauma, the basically there will be some life-threatening things you will be, you see, like that's what they have written here, that in primary survey with immediate resuscitation of patient with life-threatening injuries. Okay. So that's why they had in some in scenarios like this, that if there is some life-threatening bleeding is going on, so stopping the bleeding will be one of the first priority to. Otherwise, if the bleeding is not stopped, patient will die. Okay. So this will be a little different approach than the normal ACLS which we do. So there will be some pre-hospital care. Okay. And then when the patient reach the tri-age, according to the categorization, they will and according to the parts of the body involved. Okay. They will be doing the steps of resuscitation. Okay. And usually the resuscitation management and the involvement of multidisciplinary team will go side by side. Okay. So as I told you yesterday, that initially you will be evaluating the overall um, status of the patient. So neurologically, you will be using either AVPU or Glasgow Coma scale. Okay. And then the vitals, airway, breathing, circulation. So if you assess and there is either it will be there, like any deterioration in the blood pressure and respiratory rate. Um, so transport to a trauma center. This will be the field trial decision scheme. Okay. This is, I think, pre-hospital. So these patients should be transported preferentially to the highest level of care within the defined trauma system. Okay. So, and if it is not there, all penetrating injuries to head, neck, and torso and extremities proximal to the elbow and knee, chest wall instability or deformity, flail chest, like these need to be immediately managed. So if it is like in that case, because in the pre-hospital care, this staff cannot do anything to these things. Okay. So even this case, they will be, the priority will be to transport the patient immediately. Maybe may include some maneuvers to stop the bleeding, or if the patient is unresponsive or totally needing any like basic life support. So it is not mentioned here, but it will be part of it. Okay, because they may ask you in this scenario, usually with reference to BLS, they ask this, that you find a patient outside of the hospital, they can ask you. But ATLS, even if they are not asking in that way, if the question is like topic under the discussion is like that, maybe even they will not ask you about this one BLS, but this is logically that you have to tell about it as well. Okay, so like they are assessing the mechanism of injury and evidence of high energy impact. Okay, so high energy impact, they are just telling this is the actually some of the details we maybe we don't need it, because this is too much. I think we didn't don't we are not dealing with these things as an anesthetist. It's not there. So you can just see that if there is very high impact of injury. Okay, so some of the other points in the history, if they find older adults, risk of injury death increases with after age of 55. Okay, systolic blood pressure less than 110 may represent shock after age 65, because usually they will slightly higher blood pressure. Low impact mechanism, ground level fall can result in a severe injury in old age. So this is about old age. Okay. So like older age, even small injury can result in a bigger problem. So for children, triage preferentially to pediatric capable trauma center. Anticoagulant use and bleeding disorders, what will be the consideration in this one? Patient with head injury are at risk of rapid deterioration. Please, can you mute yourself, because it's a distraction for me. They are just telling the special scenarios. Like older adults, you need to worry about these things. In children, of course, you will be sending the patient to a place which has the capability of pediatric. Okay, anticoagulants use, or there will be high chances of rapid deterioration if the patient is already on anticoagulants or having some bleeding disorders. Okay, burns without trauma mechanism, tries to burn facility. With trauma mechanism, tries to trauma center. Okay, so this is the scenario with reference to blast injury, in which the burn and trauma will be, both of them, they will be there. Okay, so there will be special scenarios with reference to pregnancy. So this is sorry. Okay. So when this was the pre-hospital, so when in the hospital, it is better if you got the information that such patient, such and such patient is coming. So maybe you will be preparing yourself. So so resuscitation trolley, properly function airway equipment. These are the basic thing. Warm intravenous crystalloid solutions. We discussed yesterday why it is important that if you are giving cold fluids, that the chances of patient going in the. So please, can you mute yourself, please? This is okay. So a protocol to summon additional medical assistance in place. That's what I was telling you. According to the mode of injury and according to the need. So it may be laboratory, radiological personnels, even for example, radiology for fast scan, for example. Okay, maybe other specialty if it is needed to have, for example, in a scenario in which the patient need has some facial trauma or something to maintain the airway, maybe you need to have tracheostomy, for example. Okay, similarly, if bleeding, there's any problem with reference to bleeding, so maybe surgical team will be required. With reference to any head injury, neuro team will be needed. And further, because the patient may need to be transferred to ICU, so ICU team will be involved. So you just have to think about it. It's like other immediate problems. Well, maybe, for example, if there is thoracic trauma, pneumothorax, patient might need to have the provision of chest tubes. Similarly, if there is any cardiac, so patient might need to have involved cardiac surgeons. So like you will be according to the scenario, whatever. So in the summary, you can say that any required team according to the surgical, according to the mode of injury and according to the probable expected injuries, you will be involving the concerned teams. Okay, and then they can ask you how will you do it. Okay. Okay, so triage will be done with and actually there will be special scenarios if there is multiple casualties or mass casualties, like in case of any like with reference to blast, as I told you. Okay, so there will be more than one patient, so the priorities and management and work uh, system will be a little uh, having different priorities. Okay. So airway, breathing, circulation, which hemorrhage control. Like, okay, that was what I was telling you. That if there is severe bleeding, maybe C will come. So maybe C, in with reference to also the compression, as we know about it. Similarly, here also the C with reference to control of bleeding will come. Okay. So during primary survey, life-threatening conditions are identified, as I told you. Okay. There will be repetition of these things. Mm, okay. So this is the summary of what I was discussing yesterday. You will see the same thing multiple repeated. Upon initial evaluation of a trauma patient, first assess the airway to ascertain patency. Okay. This rapid assessment of signs of airway obstruction. So any signs of airway obstruction, conscious level, and then you will see the other things: facial, mandibular, tracheal laryngeal fractures, and other injuries that can result in airway obstruction. Okay, and suctioning, clear accumulated blood or secretion that may lead to airway obstruction. So with reference to airway obstruction, you will be thinking like this. Normal jaw thrust and chin lift and extension of the neck will be restricted because of restricting cervical spine motion. Okay, so you can use the word of Mills, or you can say that you will be putting the collar. Any word you can say. Okay. So, with reference to head injury and conscious deterioration, so GCS 8 is a one of the sign to have the definitive airway or rapid deterioration, and there are so many factors for which you need to have further radiological investigation. Okay. Establish a definitive airway if there is any doubt about the patient's ability to maintain airway integrity. So this will be the message for you. While assessing and managing patient's airway, take great care to prevent excessive movement of the cervical spine. Again, they are repeating based on the mechanism of trauma. Assume that a spinal injury exists. Neurological examination alone does not exclude a diagnosis of cervical spine injury. If neurologically patient does not have any deficit, apparently even then it cannot be excluded. So the spine must be protected from excessive mobility to prevent development of a progression of a deficit. Okay. So this is what they tell like this. So you have to hold the head and like you will use your forearm and hands like this. And maybe you need more manpower. Okay. So I'm sorry, let's just okay. So what next? Uh, while every effort should be made to recognize airway compromise promptly and secure a definitive airway, it is equally important to recognize a potential for progressive airway loss. Okay, frequent re-evaluation of airway patency is essential to identify and treat patients who are losing the ability to maintain an adequate air. So then ventilation alone does not ensure adequate ventilation. Adequate gas exchange is required to maximize oxygenation and CO2 elimination. Okay. Ventilation requires adequate function of lungs, chest wall, and diaphragm. Therefore, clinician must rapidly examine and evaluate each component. As you know that with the disability and exposure, you will have all the head-to-toe examination with reference to any fracture or any chest like rib fracture or anything like that. Okay. To adequately assess jugular venous distension, position of trachea, chest wall exertion, expose the patient's neck and chest, perform auscultation to ensure gas flow in the lungs. Visual inspection and palpation can detect injuries to the chest wall. that may be compromising ventilation. So whatever we are doing, we are trying to see whether there is any immediate problem, and then in the secondary survey you will have further evaluation. So visual inspection and palpation can detect injuries to the chest wall that may be compromising ventilation. Percussion of the thorax can also identify abnormalities, but during a noisy resuscitation, this evaluation may be inaccurate. Now, with reference to actually ultrasound, there will be a lot of things which you can do with the ultrasound. Okay, you can identify a number of injuries and a number of problem with reference to even in immediate focus, like the concept of focus point of care ultrasound. So you can uh, do a lot of things. Okay, so injuries that significantly impair ventilation in the short term include tension pneumothorax, massive pneumothorax, open pneumothorax, and tracheal and bronchial injuries. Okay, so these injuries should be identified during the primary survey and often require immediate attention. So that's what actually I was telling you, that immediate injuries, pneumothorax, hemothorax, even maybe they will later on they will tell about cardiac. So cardiac injury or development of cardiac tamponade is also one of the things which need to be treated immediately. Okay. Uh, every injured patient should receive supplemental oxygen. If the patient is not intubated, oxygen should be delivered by a mask reservoir bag mask ventilation. Use a pulse oximeter to monitor adequacy of hemoglobin saturated. This is normal things. A simple pneumothorax can be converted into tension pneumothorax when a patient is intubated and positive pressure ventilation is provided before decompressing the pneumothorax. So this is an important point. They have highlighted the points in the important ones. So also they have what equipment failure test equipment regularly, ensure spare equipment and batteries are readily. But this is a common things. Identify patient with difficult airway anatomy. Identify the most experienced skilled airway manager on your team. Ensure appropriate equipment is available to rescue the field. Okay, the failed airway attempt. Be prepared to perform a surgical airway. That's what I was telling you. That in case maybe you are not able to in the trauma patients, you should be ready for tracheostomy if there is involvement of airway injury is there. So maybe you are not able to intubate. Okay, recognize the dynamic state of the airway and recognize the injuries that can result in progressive airway loss. Okay, so one example for that will be that, especially with reference to any progressive edema. Okay, with reference to burn, because sometimes maybe patient is at the moment right, but after some time patient will have edema. So it is better to intubate early. Okay, so they are telling this thing is there in this words. Okay, so blood volume and cardiac output. So actually this is also with the reference to assessment of the level of shock. Okay, because there will be clinical sign symptoms which may be difficult to interpret in specific age groups. Okay, like pediatric patient, maybe the normal hemodynamic parameters will be like distracting. Okay, or any specific. So you need to know how will you like level of consciousness will be one of thing. Perfusion, skin perfusion will be one thing. Pulse, a rapid thready pulse will be like will be one sign of hypovolemia. Assess a central pulse bilaterally for quality, rate, and regularity. Okay, absent central pulses that cannot be attributed to local factors. Just give me a second, please. Sorry, actually. Okay, so identifying the source of bleeding as external or internal. Okay, external hemorrhage is identified. So this is also the point I yesterday highlighted, that some of the bleeding can be stopped by either by external pressure or with the, as it is mentioned here, tourniquet, and may be visible. But some of the bleeding, especially abdominal bleeding. So remember one thing, that abdominal bleeding is sometimes difficult to pick. So for that, you need to have either radiological CT scan, for example, or fast scan. Even some people will be very good in identifying with the clinical methods, abdominal examination, but maybe it will be difficult. Okay, but you will be considering the hemorrhage until it is ruled out. Okay, so that as written here, as the major areas of internal hemorrhage are chest, abdomen, retroperitoneum, pelvic, and long bone. Okay, the source of bleeding is usually identified by physical examination, chest X-ray, pelvic X-ray, focus as the fast scan. Okay, and DPL. If someone has attended yesterday, these were the things which I mentioned yesterday. Uh, okay, so at the same time, you will be starting. It is not mentioned here, but at the same time, there will be the team will be already starting the resuscitation. Okay, because you need to. This is a word which any person who is appearing in any oral exam. So remember this word: resuscitation, evaluation, and management will go side by side. This is a word you can use it, and this will be a very good word in that way that you are not missing the thing. So you will evaluating the things and you will managing, evaluating and management. Okay. So vascular access is a very important thing. You will try to maybe send, people will say send CVP, but actually CVP is maximum gauge you will have 16 gauge. Okay. And sometimes it needs more expertise and more, it will not be possible. So getting a big IV line will be a better option rather than trying for CVP. But of course, if you are not getting any, you are not able to get any other vein, then you may be trying for any central vein. Okay, because this thing you should be knowing. Typically, two large bore peripheral venous catheters are placed, administer fluid, blood, plasma. Okay, and then again you can have it. It will not be mentioned here, but I'm telling you extra that the modern monitors, they will even tell you indirectly the level of hemoglobin. Okay, so either you can do ABGs, you can do ROTM in the secondary survey, not in the primary survey. You will not be able to. But when you are telling in the exam that you are further management will be according to the parameters you will be getting definitely from the point of care testings, as I mentioned, ABGs and ROTM, everything, and thromboelastography. Okay, they have written here blood samples for basic are obtained and including a pregnancy test for all females of childbearing age. Okay, blood price and cross match, because and this way, and then as extra thing I am telling you that maybe if the patient is like too much hypovolemic, so maybe you also use the word that maybe you need to activate the massive transfusion protocol. Okay, maybe you don't have time for cross matching. You need to have uncross match O negative or O positive blood group. So this is also something you need to tell even in the written exam, or maybe this may be a consideration which you should be knowing. When peripheral side cannot be accessed, intraosseous or central line, okay, or even venous cut down. Okay. Mm, Again, maybe the use of ultrasound to get the IV access, you can mention. Aggressive and continued volume resuscitation is not a substitute for definite control of hemorrhage. So this is very important, because maybe you are giving too much fluid and still there is bleeding. So ultimately you need to stop the bleeding source, even it is internal bleeding or external bleeding. Okay, so because if you are over resuscitating, then the lethal triad can go and patient can go in DIC. Okay, the same thing they are repeating. Okay, so arrive with coagulopathy already established, which had led to some jurisdiction to administer tranexamic acid preemptively. This is something else. Okay, with reference to disability, rapid neurological evaluation establishes the patient's level of consciousness and pupillary size and reaction, identifies the presence of lateralizing signs, and determines spinal cord injury level. Okay. The GCS is quick, simple, and objective way. And maybe other things in addition will be, for example, hypoglycemia, alcohol, narcotics, according to the patient level of consciousness. This will becoming in the what we say in the after primary survey, the secondary survey. There is, if I'm not wrong, there is a mnemonic of ample. Maybe it will come here. Um, okay, so indicates the need of an altered level of consciousness, indicates the need to immediately reevaluate the patient oxygenation, ventilation, and perfusion state. Okay, and hypoglycemia is one of the important thing. Primary brain injury results with the structural effect, and as I told you yesterday, that if you find that there is some a correctable source of head injury, like sorry, corrective source of bleeding, and you will immediately, if there is any neurological deficit, is there is as they're saying here, any neurological sign, the GCS, vomiting, fits. So maybe patient will have CT scan, and in CT scan, maybe if there is some bleeding which can be evacuated. Otherwise, you can say this will be a sort of prevention of secondary brain injury, because primary injury will already be done. So secondary brain injury first will be that you remove that source of bleeding which is compressing. Okay, so this will be first thing, and then second thing will be to avoid the factors which can lead to secondary brain injury, that are the normal good factors like CO2 and O2 and temperature and everything. Okay. uh, okay, so neurosurgeon and neurosurgical facility you should be sending. Okay, so after during the primary survey, completely undress the patient as I told you, and cover the patient. After completing the assessment, you will cover it with warm blankets and or an external warming device. Warm intravenous before infusing them, and maintain a warm environment. Okay, there should be a question that if we are saying about prevention of hypothermia, but if in certain conditions you will avoid hypothermia, sorry, you will avoid hyperthermia, because hyperthermia will lead to bad neurological outcome. So again, there will be certain conditions in which you will need to have some hypothermia. That will be separate. That, like, this is a little tricky answer to tell. Okay, because in majority cases, when you are having hemorrhagic shock, actually you should avoid hypothermia. Okay, but if the condition is like that, that there is some neurological injury insult as well, so now you have to evaluate accordingly. You have to cover both ends. Okay, maybe you can use some other, there are so many techniques for avoiding secondary brain injury. So you maybe, the temperature is one of them. Okay, hypothermia can be present when the patient arrives, or it may quickly develop in ED if the patient is uncovered and undressed, undergoes rapid administration of room temperature fluids or refrigerated blood, because hypothermia is potentially lethal complication. Okay, and take aggressive measures to prevent the loss of uh, so okay, the same thing they have told. Hypothermia can be present in admission. They are the same thing they are telling here. Adjuncts to the primary survey with resuscitation. So, a number of things we have discussed: continuous echo, continuous ECG, pulse oximetry, CO2, assessment of ventilatory rate, ABGs. Okay. In addition, urinary catheters, especially with reference, not only you will be assessing the urine output to see the level of like volume status, also for hematuria. Okay, as I told yesterday, that there are more chances with reference to pelvic fracture and involvement of urethra and urinary bladder. Okay, NG tubes. The Of course, in this scenario, you will be needing NG gastric catheters, decompress, distension, assess evidence of blood. Okay. Other helpful tests include blood lactate, X-ray examination, chest and pelvis, fast, extended focus assessment with sonography for trauma. This is something new for me. Uh, Extended focus assessment with sonography for trauma. This is maybe something extra. Anyways, and DPL, diagnostic peritoneal lavage. Okay, physiological parameters such as pulse rate, blood pressure, pulse pressure, ventilatory rate, ABG levels, body temperature, urine output. All these parameters we will be seeing. Okay, ECG, like any arrhythmias and like atrial fibrillation, PVCs. Okay, this is what I was telling you. Pulseless electrical activity can indicate cardiac tamponade. Okay, so in the T's, the correctable T's and you will for H and T's with reference to. Okay, so this will be one of the priority. Mm, Extreme hypothermia also produces this arrhythmias. Okay, so with reference to like, this is very bad. I'm requesting all of you to mute the mic again. Anyways, okay. So pulse oximeter and a small sensor is placed on the finger, toe, ear lobe, and another convenient place. Most display pulse rate and oxygen saturation continuously. The relative absorption of light by oxyhemoglobin. This is they are just telling the pathway. They have not mentioned here, but there are special pulse oximeter in which you will also see the hemoglobin level. It will not be 100% accurate, but it can give you a rough idea. Okay. Mm, By the way, ultrasound will also be need to, you can confirm the position of endotracheal tube with also with the ultrasound. You can also see the gastric volume with the ultrasound. Focus will also be giving you these things. Okay. Okay. So because recently end-tidal CO2 now is part of even cardiac resuscitation. So that's why they have mentioned here and end-tidal CO2. So other thing, urinary gastric catheters, we have discussed about it. Transurethral bladder catheter is contraindicated for patient who have urethral injury. So as yesterday I told you that in that scenario you will have to need the suprapubic catheter. Okay, and by the expert people, expert urology team. Okay, so if you are trying to have the this Follies and you are not able to pass it, don't push. Number one. And the other thing is that if you have suspected pelvic fracture, it is better to involve urologist from the start. Okay, so this is one of the extra things. So gastric catheter, NG tube, they have just to decompress the stomach, decrease risk of aspiration. Okay. Mm, 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 mm. It again, remember one thing that it will not, you will not be able to have the aspiration of the solid particle. So this is still a controversial thing in some conditions, but in this scenario, if you are suspecting bleeding, you have facial fractures and like things like you are expecting that there will be blood inside the stomach. So if you don't aspirate it, this will there will be a risk of aspiration with it. So that is one of the reason to decompress the stomach. Okay. So radiological studies will be done with pan CT or pans like different X-rays. So you will be evaluating your purpose is the same, that you are evaluating the further any injuries. You are ruling out long bone fractures. You are ruling out rib fracture. You are ruling out any hidden bleeding. Your purpose is that. Okay. A diagnostic peritoneal lavage, I think if there is some like contraindication, like it is, for example, pregnant patient. So these are the things in which you will not be doing certain things. Again, this is a actual subspecialty thing. You don't need to know uh, too much details. Okay, DPL can be challenging to perform in patients who are pregnant. Okay, or who have prior laparotomies or are obese. So it is not a good technique. No, I have never seen being done frequently. Of course, in the emergency, sometimes it is needed. Surgical consultation should be obtained before performing this procedure. It's not your domain actually. So, but I have seen some of the examiners, they are very interested in asking this question. Even I have heard that they even asked how to do the peritoneal lavage. It's none of our business. It's surgical. It's surgeon's job. Okay, during the primary survey with need of patient transfer. So whenever you are in a situation or in a setup where you need some, so same time you will be trying to transfer the patient to a place where better facilities or advanced facilities uh, are needed. Okay, uh, I will stop here. Okay, because this is a slightly lengthy topic. That was actually ample, which I was telling you. Allergies, medication, past illness, last meal. Okay. So, any questions from the discussion we did today?
Yes, sir.
Yes,
Sir,
please.
I have a question. Sir, will we
Yes.
order this PAN CT after primary survey? Is it mandatory or only symptom? If the patient has any symptom, then we will order CT scan.
Actually,
PAN
if
CT.
yes, you are absolutely right. Pan city according to the scenario, according to the mode of injury. Okay, and if, for example, especially the purpose of primary survey is to immediately pull out the patient from danger. If, for example, you are whatever resuscitation you are doing is getting fruitful. Okay, the, sorry. So maybe in such scenarios, maybe you will, please, Dr. Sajid Ali, please mute your mic. Okay. So in this scenario, maybe you need to stabilize the other things before going for PAN CT. Okay. But you have any doubt, like for example, you have any doubt about abdominal bleed, or there is, for example, in RTA it is mandatory. Okay. Or maybe there is another, because your question is very valid, but maybe you can in your our exam, in anesthesia exam, maybe you can say that maybe fast scan is being done. Okay, and if there is anything doubtful, they will go for the further evaluation. Okay, so maybe I think this would be the appropriate answer. Okay,
Okay, sir.
if you have any doubt, or if the mode of injuries is warranting it, or your resuscitation is going out of context, like you are giving fluid, you are giving blood, and there is no obvious reason, then you need to have horror evaluation with reference to thorax or abdomen at least. Okay, of course, pan CT, not, maybe I'm using this wrong word, not pan CT, abdominal CT and thoracic CT. Okay, because
Sir,
other will
because
be,
generally,
yes, yes, please.
yes, sir. Sir, generally we see the patient in Saudi Arabia. Every
Mm.
patient comes with PAN CT. All
Yes,
reports are there,
yes, because they want to rule
irrespective
out,
of their.
they don't want to take a chance. Okay, so that was the reason. And usually the terrible accidents which we face here. Okay, so you had enough experience here, you know very well that in these cases sometimes there are a lot of injuries. Okay, like I will just share that today I just had a terrible patient in the way that he was making the video and he was driving the car at around 200 kilometers per hour, and he had accident, and luckily it was a desert, and he was thrown out of the car and he fell down in the sand. So only he did not have any head injury, he had pelvic fracture, so he was there for bilateral pelvic fixation. So I'm just there are so many things in the world. So I think the correct answer can be given by the surgeon, but usually I think they don't want to take a chance, and that's why they do the CT scan to rule out any source of bleeding. Okay, so thank you very much. Maybe this topic will need some time for a discussion, but because this is being asked number of times, so I'm just trying to give an overview. I think maybe we can get ATLS certificate also, because I was just saying I never read this book before, and I'm just seeing that the normal thing which you are doing, it's the same thing which is written here. So thank you very much. Bye bye. Inshallah, we will continue our discussion tomorrow.